Okay, we'll go ahead and get started. Welcome to October 16th COVID Echo. We have a really great presentation today by Dr. Brown. And Emily, if you will do some housekeeping.
Yes, good morning, afternoon, everybody. Thank you for coming today. I am putting the continuing education credit claim link where you just have to fill out your contact information and what kind of credit you would like to claim. You need to fill that out to get CEUs. And then towards the end of the meeting, I will share a link to an evaluation link. You also need to complete that to get continuing education credit. But even if you're not getting CEUs, we would like feedback. So fill out the second link if you're not getting credit. I'm going to invite everybody to mute themselves if they haven't done so already. Please don't take offense if we mute you. Feel free to type questions into the chat box or interrupt the presenters while they're presenting, unless they say it's not okay. And I think that is all.
Thank you, Emily. And we'll go ahead and get started with, Imani Ransby. She'll give an update on the USET area.
Hello, everyone. Can everyone see my screen here?
Yes.
Okay. Alrighty, so good morning, everyone. As mentioned on our last ECHO session, we have now updated our weekly COVID-19 surveillance reports that we send out on each Friday. So I'll just spend some time going over the updates that we've incorporated and take a look at the new graphs here. So this table listed includes some data points that we decided to include in the new report, so you will see those. We feel that including this information will just give somewhat of a better idea of what's going on in the USET region currently. And so we have here for this week the number of positive COVID-19 tests at all of our USET clinics in the last week was 60, while the cumulative total of positive COVID-19 tests at all USET clinics was 2,072. And then the 7-day positivity rate at all USET clinics was at 5.9%. And so we have decided to include these data points on the new report. On this slide here, the following graph displays the number of new positive test results from week to week. This was compiled from testing data sent in from the 26 sites that are currently reporting to the Indian Health Service. And so as you can see from this, we started off here with 87, and it kind of seemed to slow down in the middle of August 27th, the end of August. Sorry, these numbers are kind of small. So yeah, the end of August, beginning of September, we started to see a dip, and now it's somewhat seeming to increase again here as we enter into our fall season. And so this graph replaced the one that you probably are most familiar with seeing on these updates. Instead of just reporting the current week's cumulative incident rates by per state in the United States, we've now expanded this to include retrospective data from the past weeks, and then still include the current week's data as well, just to see what the rates have kind of done over time here. So as you can see, the USET county rates it started off here, missing a data label. Started off higher and has decreased over time. And that has also been reflected for states as well as the US rates as well. So that is something to keep in mind. And we will continue to put these reports out each Friday. And so look forward to that today.
Monty, can I interrupt you real quick?
Yes.
So if you could flip back a couple of slides. No, go forward. One more to the rates. So I just wanted to ask you all, we were putting these reports out on Fridays. And when we were doing the previous reports in which we were reporting day-to-day changes, that was fine and it made sense. But Amani and I just had a conversation just 15 minutes ago about maybe moving the release date to Tuesdays for this report. That way you would get a full calendar week of what's happened at your clinic. And I just wanted to throw that out there to see if that matters to you at all, whether it's a full calendar week or whether it's Thursday to Wednesday. Let me get your thoughts. And specifically this graph right here, I just wanted to touch on. This is the rate of new cases. So we wanted this to be kind of an early warning system about what's going on in your surrounding communities. Any spikes in rates would indicate that, you know, cases are going up relative to your population. So let me just throw that open for just a second to ask about a Tuesday release, if it's going to matter one way or the other or not to you guys. Anyone? So I'm taking it doesn't really matter either way. Okay. All right.
Alrighty. Yeah, if you guys or if anyone would like us to move to that or have questions or concerns regarding that, then please feel free to reach out to us. And you can reach us at usetepi@usetinc.org. We're also here to help if you would like to get access to our surveillance tool in REDCap or for just any general assistance if need be. Thanks.
Okay, great. Thank you, Amani. Now we'll get started with Dr. Brown's presentation.
Okay, how's the sound quality?
Sound quality is good.
Good. I think Taloa's going to advance my slides so that my internet here is not that good, and so I need as much bandwidth as possible just to do the audio, I think. So today I'm going to talk about COVID-19 vaccine prioritization. It certainly is not too early to be thinking about this. If you'll go to the introduction slide, Taloa. Thank you. So welcome to day 220 of the pandemic. It's hard to, well, it's not that hard to believe that it's been going on that long. It seems like forever. So what I'm going to talk about today is planning for vaccination when we get a vaccine. I'm going to talk about some knowns and some unknowns. And then just a few things to think about. This is not going to be all inclusive. We'll do a talk in 2 weeks on vaccine distribution plans that I'm sure will cover some of these things in more detail. But what I'm mainly going to talk about today is vaccine prioritization and how to make a plan for that. Because most likely we will not have enough vaccine for everybody at the beginning. And so we'll have to prioritize who gets the vaccine first. If there's time today, I'll also do a little bit of an update just on where some of the phase 3 trials are. And at the end, I'll leave you with some resources. So opinions expressed are my own, and I don't have any disclosures to make since my wife sold her pharmaceutical company stock. Next slide, please. So let's talk about first what we know. As of this week, there have been 38 million cases and over 1 million deaths worldwide due to COVID-19. In this country, we're approaching 8 million cases and over 217,000 deaths. We know that this pandemic is not going to end anytime soon, just of its own accord. We don't really have any targeted therapy. Most of the therapy that's being done for even the sickest hospitalized ICU patients is just supportive. There are a couple of drugs now, namely remdesivir and dexamethasone, that seem to be helpful, but we don't have any magic bullets yet. Maybe some of the monoclonal antibodies that are in phase 3 testing now, like one that was given to the president when he was sick, maybe those will be the magic bullet we're looking for. The other thing about this, knowledge is constantly changing. So, Dee, is anyone else having trouble hearing me? Is it better now?
Yeah, it's better now.
Okay. So knowledge is constantly changing. What's true today will be proven not to be true next week, and what we thought wasn't true this week will be proven to be true next week, and then it'll all change again. So it's really a challenge to keep up with all the changing knowledge and studies. We also know that certain people are more vulnerable to poor outcomes if they get sick. Then the last thing that I'm going to say that we know today, and this is really from experience with previous epidemics and diseases, vaccine or vaccines can help to end the pandemic if, and there's a big if there, if the vaccine is relatively efficacious and if a whole lot of people agree to get vaccinated. Right now, we don't know how efficacious any of the vaccines will be. There's some promising data from the phase 1 and 2 trials of some of these vaccines that they will be highly efficacious, but we don't know that yet. The amount of uptake in the US is anybody's guess. I shouldn't have put that as what we know. We do know that we'll need high uptake if the vaccine is going to end the pandemic. But some of the recent polls have shown that probably as many as a third of our countrymen say they're not taking the vaccine. Unfortunately, there's been a lot of, I think, politicization around this, and that's not helped anything. There's also just there's an awful lot of vaccine fear in the US that's kind of been propagated in the last couple of decades. And if you look on social media, there's just all kinds of misinformation and fear about vaccines out there. Next slide, please. So there are a lot of unknowns, and I'll just mention a few things that we don't know. We don't know right now how long the pandemic will continue without effective intervention. We don't know when an effective vaccine will receive an emergency use authorization by the FDA and be recommended by ACIP. We don't know how efficacious the vaccines will be. The FDA has said that if a vaccine is 50% effective, then they will approve it. If we get 70% efficacy and we get 70% of the population to take the vaccine, there's a pretty good chance that that will give us a degree of herd immunity and probably end the pandemic. But you know, we don't know if we're going to get a 70% efficacious vaccine. And we don't know if we can get 70% of the country to take it. Right now, we're not sure what the supply, especially initially, of the vaccine will be like. We don't know for sure how many doses will initially be available. And then there are a whole bunch of things that we don't even know that we don't know. These are the unknown unknowns, and these are probably endless at this point. Next slide, please. Excuse me. So just want to throw some things out there. This is certainly by no means an all-inclusive list, but just some things that those of us who are in any part of the planning for vaccination need to be thinking about. First of all, how to acquire vaccine. There'll be a lot more about this that comes out over the next few weeks. Possibly 2 weeks from today, you can hear more details about what's known now about how to acquire vaccine. It looks like for at least one of the vaccines, the minimum order will be 975 doses. I put 1,000 just to round up, but one of the vaccines that has to be kept ultra cold comes in trays of 975 doses. So that's the minimum amount that you can order. So for people that, if that's the first vaccine that comes out and you don't have 1,000 people to give it to, there'll need to be some mechanism for sharing with some other entity. The rest of the vaccines, the minimum orders will probably be in the 100 to 200 dose range. Need to be thinking about how to store vaccine. And if we get to my vaccine update today, I'll talk a little bit about temperature. I think there have been a lot of questions about that with people. What's really important is communication. You need to be communicating to your clinical staff, but especially a public education plan. It'd be great to try to dispel some of the fear among the public about the vaccine. It'd also be a good thing to be ready to tell people exactly how and when to get the vaccine. What we'll talk about more today is administering the vaccine, and that is, what are the target populations? Who are the first people that need to be vaccinated? Who are the second group and the third group? Record keeping, of course, is very important. Most of you already have very robust systems in place to record vaccine. It'll be especially important to have a follow-up system because most of the vaccines that will be initially available will require 2 doses. And the vaccines are not interchangeable. So it's critically important to know what vaccine somebody received the first time, because they have to get the same vaccine the second time. We also need to be thinking about who is our community. And that, of course, is up to each tribal nation to decide for themselves. But you might want to think in terms of not just the enrolled members or the beneficiaries of your program. IHS regulations allow for vaccinating non-beneficiaries if it is a public health type service that protects the wider community. So, you know, you might think about non-Indian family members, you might think about non-Indian employees of the tribe. But we really need to define who the community is. The other thing, if you have this information, is to go back about a decade to the H1N1 pandemic and review your experience with that. You know, what from that vaccination campaign, what sort of lessons did you learn? What went well, what didn't go so well, and what can you apply to today? Next slide, please. This is a graph that you're probably going to see a lot over the next couple of months or so. I don't want to get lost in the weeds here. There's a whole lot of very tiny print that's hard to see, but basically you see what looks almost like a bell curve type graph here. So in the beginning time period, there will only be limited doses available. The supply will be very constrained, and so we need to target the highest risk populations first. As time goes on, they expect that there will be a fairly quick ramp up as more vaccine becomes available, and you may have large numbers of people to consider at that point. And then over time, as lots of people get vaccinated, we'll need to shift to more of a routine strategy. One of the unknowns right now is how long will any of these vaccines confer immunity? It's probably doubtful that there'll be lifelong immunity kind of things, you know, one shot or two shots, whatever it takes, and you're done. It's quite possible that the vaccine will only give immunity for a few months or a year or two. And it may be that we start giving this vaccine annually, just like we now give the annual influenza vaccine. Next slide, please. So initially, if there's not enough vaccine to go around to cover the entire population, we really need to give priority to groups that are based on either their potential exposure or their vulnerability due to age or medical comorbidities. And the third factor that we might want to think about is which groups have the highest potential to spread the virus. I'll talk more about all of this as we go along. Next slide, please. So I think it's helpful to think in terms of phases. So there are a couple of publications that at the end of this talk, the last slide has some resources for you. The federal government commissioned the National Academies of Science, Engineering, and Medicine to come up with an equitable allocation plan for COVID-19 vaccine when it becomes available. And they've produced a 237-page document. I challenge any of you to read all the way through it. It's very comprehensive, it's very good. And most of what I'm going to say about prioritization is based on that document. The CDC also recently released a document called, what is it called? COVID-19 Vaccine Interim Playbook for Jurisdiction Operations or something like that. It's kind of an odd title, I thought. But anyway, that is a much shorter book. There are more pictures and stuff, so it's quicker to read, but that's a very comprehensive planning book. And I encourage all of you to download that and start looking at it if you haven't already. And then just this week, the Indian Health Service released their plan, and that link will be at the end of this talk as well. So in the first phase, these are the groups that probably need to go first. Healthcare workers, because they're exposed all the time. Now, this wouldn't necessarily be everybody that works in a hospital or clinic, because some people don't have any exposure, but it is going to include certainly all the frontline people, the nurses, the pharmacists, the doctors, the lab techs, the people who do the cleaning, anybody who has extensive contact with either patients or patient samples. So the other group that has a very high exposure risk are first responders. So policemen, emergency medical system people, and firefighters. There may be other people that you can think of that would be in this group as well. Then elders who are in congregate living situations, those who are in nursing homes or assisted living. And the reason that a high priority should be placed on them is that this is the group that's had the most mortality. They've had the highest rates of mortality. And once COVID hits a nursing home, it tends to really spread rapidly. So these are the most vulnerable elders, and they need to be protected. And then people of all ages who have comorbidities that are associated with worse outcomes from COVID-19, and I'm going to talk in more detail about that. And then I've put a question mark here about all elders, and at what point do you draw the age line for them? The official guidance right now is saying people over 65. But in truth, pretty much every age group, the mortality and morbidity goes up as the age goes up. So, I guess we would start with the older people, the 65 and older, and maybe work our way down to the 50 years group. So if you just look at all of these people, and that has been done by Christina Rogers, phase 1 could easily be 50% or more of a tribal community, because there are a lot of people that fall into these categories. Next slide, please. So these are medical conditions that are the highest risk. These conditions have the highest risk for bad outcomes. So people that have cancer, or the people that are being treated for cancer, or cancer survivors, chronic kidney disease, COPD, somebody who's had a solid organ transplant, like a kidney or liver, heart, lung transplant. Those people have to take some pretty strong immunosuppressants every day. So those are ones that are at highest risk. And then people who are overweight, actually the highest risk are people with a BMI over 40, but there's some risk with a BMI over 30. And then people with serious heart conditions like congestive heart failure, cardiomyopathy, or coronary artery disease, sickle cell disease, type 2 diabetes, and recently smoking has been moved into this highest risk category by the CDC. As more data has come out, it's become more clear that smoking is a high risk behavior for serious outcomes from COVID-19. And if you want to look at this for yourself, the CDC website link is there at the bottom. Next slide, please. These are medical conditions that are possibly at increased risk. There's less data to support this, or the data that does support it shows that it's not as high risk as those other conditions that I just mentioned. So moderate to severe asthma, neurological conditions such as stroke or dementia, other lung diseases like cystic fibrosis or pulmonary fibrosis, hypertension. I was a little surprised to find that this is not in the first group, but I guess there's a strong association with it because so many older people have hypertension. But I guess overall hypertension alone is not quite as big a risk. There are other immunocompromised states, such as people who have had bone marrow transplants, people living with HIV, various relatively rare immune deficiency diseases, or people who are taking immunosuppressant medication, like people who are on chronic steroids for some kind of rheumatologic disease. Liver disease probably does increase one's risk for a bad outcome. And even being not obese but overweight has been shown to confer some extra risk, although not as much as severe obesity does. Pregnancy has increased risk, thalassemia, which is quite rare in our population, and type 1 diabetes, which is also fairly rare. And again, the link to the CDC website is there at the bottom. Next slide. So if you don't have enough vaccine to cover everybody in phase 1, what do you do? Well, I would recommend that you probably first prioritize those who are at highest risk of exposure, people who really have to be exposed because of their job. So healthcare workers and the first responders. The next highest group would probably be those elders who are in nursing homes and assisted living. And then the next subgroup in phase 1 should be people of all ages who have medical comorbidities that are associated with the higher morbidity and mortality. So that first slide that I showed you, especially people that have 2 or more of these conditions. And then I think the elders should probably come next. Next slide. So once there's more vaccine available and we're moving to sort of phase 2, who should those be? Well, first of all adults who are 65, or if you maybe even 50 or older, who were not vaccinated in phase 1. K through 12 school staff and childcare workers would be next. And then workers who are essential to society function because they're at higher risk of exposure, like people that work in grocery stores, public transportation, mail carriers, or post office workers, government offices because they deal with the public a lot. And then staff and occupants of homeless shelters or group homes or detention facilities are at higher risk. And then, of course, you should definitely try to cover all those that got missed in phase 1. Next slide. So moving into a situation where we really have probably an adequate vaccine supply. These are large groups like young adults 18 to 30, children under 18. Now, there will not be an approved vaccine for children under 18 until the studies are done. And who knows when that's going to happen, but it's probably not going to happen for several months after the first vaccine comes out. And then workers who are in occupations important to society functioning, but they weren't included in phase 1 or 2. Next slide, please. And then phase 4, just everybody you can vaccinate. You'll notice that people from 31 to 64 weren't mentioned anywhere. That is healthy people with no comorbidities. They don't work in a job that places them at high risk of exposure. Why do we prioritize 18 to 30-year-olds before we might prioritize the sort of middle-aged adults, 31 to 64? Well, it's because the 18 to 30-year-olds are more likely to be spreaders. They're when I've had this discussion with people, they say, yeah, it's because they don't listen. Sorry for those of you who may be in that age group. I know that that's not universally true. There are, of course, very responsible people in that age group, but I think we all know that the 18 to 30-year-old crowd, social interaction is very important to them, and it's very difficult to get them to isolate or to socially distance. So I've talked about this sort of in some general and specific terms. For your particular tribal nation or your community, there may be some other priority groups that you would consider putting ahead of some of these other groups. There's really no one-size-fits-all plan. You really should think about your community and how you want to prioritize. I think tribal governments need to definitely be included in this. And it's probably good for more than 1 or 2 people to be making this decision. It's probably good to have a committee. Next slide, please. So here are some resources. There's the link to the Indian Health Service COVID-19 pandemic vaccine draft plan that just came out this week. It's on the IHS website. And then that CDC interim playbook, sounds like something for a football team. And then the long document with no pictures is the framework for equitable allocation of COVID-19 vaccine. I think probably one of the most valuable things about that very long document is that it goes into very fine detail about the rationale for each priority group and why they're prioritized the way they are. So it's a good reference to have on hand in case people, start arguing about, well, I think this group should be ahead of this group, or I think this group needs to go last. You can refer to this and read their rationale, and I think it really can give you a lot of help in making those decisions. And I think that's the end of this presentation. I thought we'd take time now to answer questions, or we could have a discussion if people want to talk about their experiences so far with planning for vaccine allocation. This would be a great chance to share. So could we go back to the view of everybody and see if anybody has questions or anything they want to share with us? Looks like Dr. Bunio wants to share.
Hey, Harry.
Hi.
So this is in place of me not answering your email the other day,
Okay.
thanking you to advise us about our vaccine plan. Was there anything in everything that you read about what do we do with people who have had COVID and recovered, or this group that kind of snuck in somewhere and got an antibody test that showed they had a certain level of antibodies? Are we just going to ignore any possible natural immunity?
That's an excellent question, and I don't think anybody really knows the answer to that right now. I think from what I'm reading, the recommendation is going to be just vaccinate those people, because we don't know how long the natural immunity will last. There's starting to be evidence that for some people, it doesn't last very long at all. There have been people who have had documented COVID cases who recovered, and then 3 months later had a second documented COVID case. The other thing about at least some of the phase 1 and phase 2 data from some of these vaccine trials, the vaccines are actually giving a more robust immune response on average than the natural disease does on average. Now we'll see if that really pans out in some of the phase 3 and other phase 2 studies, but at least with both of the messenger RNA vaccines, as well as the new kid, the protein subunit vaccine, they've been giving immune responses that exceeded on average those of the natural infection, which leads some vaccine experts to believe that vaccine may actually confer longer lasting immunity than the natural disease does. So it's probably not going to hurt anybody who's had COVID to get the vaccine. So I think the recommendation will probably come out to, not test for antibody, just give it to everybody.
Okay, thanks.
Sure. Does anybody else have any different information on that question? Because I'm by no means an expert.
It's been several weeks since I participated in some of the planning calls, so my information may be out of date. As we know, it's changing very, very quickly, but that was kind of my understanding as well. Of course, we'll be monitoring, and everything is subject to change. I did want to know has anybody heard from or reached out to their local state health departments about sharing vaccines should the quantities be too large for a tribal clinic, and how that might work? I know that I was on the FEMA Region 1 planning call, and that they were talking about that. And I think that those relationships probably need to start getting made if they have not already, if that has not already begun. So has anybody heard from their state or local health department about that?
Christy, hi, it's Dr. Johnson. Thanks for bringing that up because that's an important point. One of the things that we're doing in the Nashville area is, number one, we're gathering those numbers for each tribe as far as who will need to be vaccinated, looking at those numbers and recognizing that some of those vaccines come bundled. I think one of them is 1,000 and you have to get it done within a certain period of time, with the max, I think, is 10 days out. And so trying to vaccinate 1,000 people in 10 days for most people would be a huge undertaking. And so what we have done within the national area, our pharmacist point of contact is Nathan Wyatt. And he's actually going to be looking at tribes, seeing what their number of vaccinations they need and seeing what that would look like. So that's something that we're working on, trying to look to see the first steps of that possibility of vaccination sharing. It doesn't mean that we are, we're going to require it, but we are at least trying to see how that would look should we have to go down that road.
And 2 weeks from today, Commander Wyatt is scheduled to speak on that. So hopefully you can all tune in 2 weeks from today.
So this is Dee, the health director for the Passamaquoddy Tribe at Indian Township. We have been involved in all of our state planning discussions around the vaccine distribution, which has been kind of different for us. We usually hadn't been involved in stuff like this, but they have been reaching out more frequently, and our relationship has really grown in the last 2 years. One of the things that we had discussed was one, obtaining our vaccinations for our patient population through IHS, and then getting our workforce vaccinations through the state. So having that coordination. The state had agreed to support us in any way that they can. We also talked a little bit about that concern about the 1,000 dose scenario and what we could do collectively as with 5 tribes in Maine or with some neighboring counties. We have had those discussions. One of the things that they had mentioned to us was that those 1,000, what is it? They said this it's going to be in, what did they say? I know, Teresa, I know you're on 1,000 dose packages, but in 5 dose vials. So that was something a little bit easier that we could probably deal with. So we started planning amongst each other and how we can do that. I know the state is submitting their plan today. We had a listening session with them on Wednesday and a consultation session on Tuesday. So they are working with us. I think we're doing as much as we can with the limited information that we have. But they have shown commitment in doing whatever they can to assist us in what makes the most sense.
This is Rick. So in North Carolina, the state kind of asked us, did we want to participate in their vaccine distribution? And our public health department said we would use IHS. They've been very cooperative. I think we just figured we had another conduit. We'd try to get our vaccine through IHS and let the state use what they got. Which kind of raised a question in my mind, Dr. Brown. Is it possible that IHS would use a different vaccine than the state?
It's quite possible. If we have time, I could go ahead and do a little update about the vaccines that are most likely to come out first, if people want to do that. We're having good discussion. We can continue to do the discussion, but yeah, in answer to your question, yeah, I think it's quite possible that IHS could have one vaccine, the state could have a different one. You could still use 2 different vaccines. You just have to be very, very careful about who you gave which vaccine to, because they're not interchangeable. Even the ones that use the same technology are not interchangeable as far as anybody knows at this point.
Okay.
Any other questions or comments? People tired of hearing me talk, or should I launch into the other session I could do?
Go ahead and do your other presentation.
Okay, I'll try to keep it fairly brief, but Taloa, could you pull up that second presentation? And I'm going to go off video to enhance my bandwidth here. Hopefully you can hear me without the sort of robotic thing that sometimes happens with Zoom and low bandwidth. Go ahead and go to the next slide. So just a little bit of review first. You know, a desired vaccine would be one that was safe, no serious side effects, effective. It would produce both neutralizing antibodies and give a vigorous T cell response. It would have proven efficacy in diverse populations. As I already mentioned, the FDA sort of floor for efficacy is 50%. Hopefully they'll be a lot better than 50% efficacious. Those three things are have to haves. You know, it has to be safe, it has to be efficacious. These other things are desirable, but you know, we can live with them if it's not inexpensive. Fortunately, the federal government has ponied up to say that they'll cover the entire US population free of charge. Well, we pay for it through our tax dollars, but no individual will have to pay for it. It'd be nice to have a vaccine that could be easily manufactured in large quantities, easy to deliver and easy to store, and then easy to give to large populations. There are some vaccine technologies like the DNA vaccines that require some special instruments to give. You can't just give it in a regular old syringe. Next slide, please. There are currently 8 major vaccine technologies. Only those first 3 are ones that have really been used very much. The 2 viral technologies are really old, dating back almost 100 years. The protein subunit technology has been around since the 1980s. These other 5 technologies either have never had a human vaccine approved. The viral-like particle, there's if I'm not mistaken, one of the HPV vaccines uses this technology, but that's the only human vaccine that uses VLP. There have been some successful viral vector vaccines, especially for Ebola, but these are not in common use at this time. And then the genetic vaccines, there have been some successful ones in veterinary medicine, but not yet human medicine. Next slide. So up until fairly recently, the leading candidates were some inactivated viral vaccines, some non-replicating viral vector vaccines, and then messenger RNA vaccines. Next slide. The latest one to enter into the phase 3 trials is actually a protein subunit vaccine, and I'll talk more about that in just a minute. Next slide. I don't know if we want to go. Yeah, I'll go over this. Just briefly, kind of to review. What happens in a natural infection? A virus comes into your body, usually through your nose or mouth, maybe your eyes. It goes in, attaches to cells, enters the cells, and then it starts to replicate. Eventually, an antigen presenting cell, and there are several different types of these in the body, but that comes along and says, hey, we have a problem. There's a foreign invader here. And they snatch up some of the viral antigen. And then a helper T cell comes along. The antigen presenting cell says, hey, buddy, I got an antigen for you. The helper T cell recognizes it as foreign, and then it starts to recruit other type immune cells. Next slide. Most of these immune cells are lymphocytes, and there are 2 kinds of lymphocytes. There are B cells and T cells. Now, there are quite a few different types of T cells, but these are kind of the 2 arms of what's called the adaptive immune system. That is the part of your immune system that is to a specific virus or bacteria or toxin. So B cells are the ones that make antibodies. And so if you have a viral infection, the B cells can make antibodies that are specific to that virus. And then those antibodies bind to the virus and either prevent it from attaching to cells, or prevent it from entering your cells, or prevent it from replicating. But there's another arm called the cell-mediated immunity, and this is the so-called T cell response.
Dr. Brown, did we lose you? You may have frozen up. Let me try to shoot him a message. Brian, are you the admin? Could you mute him and unmute him?
It won't let me. Just a
I
reminder.
think we lost.
Yeah,
I think we lost him.
there he is.
Am I back?
There he is. You're back.
Sorry, my internet cut out, which seems to happen frequently. At what point did I cut out? Did I talk about the memory cells?
No, you weren't quite there yet.
Okay, so after an infection, memory cells, either memory B or memory T cells, are produced. And then if you're ever exposed to the virus again, these cells are reactivated, start to replicate and make lots of antibody and do their cytotoxic thing. Next slide, please. So viral vaccines are made by either taking a weakened virus that's a live attenuated vaccine, or an inactivated virus, or just part of the virus. And you make a vaccine out of it, you put the vaccine into the person, and then the immune system responds pretty much the same way it would with a natural infection. And you make those memory B cells and memory T cells so that the next time the infection comes along, or maybe the first time the actual infection comes along, hopefully, your body has immunity to it. Next slide. Let's take a little test here. According to the WHO, as of early this month, how many COVID-19 vaccine candidates were in phase 3 trials? Was it A6, B, 9, C, 10, D, 14, or E, none of the above? You don't have to answer out loud, just answer in your head. And the correct answer is, next slide, it's 10. So this is just a little comparison between September 21st and October 2nd. There were 187 total candidates, with 38 in clinical trials and 9 that were in phase 3 on September 21st. A little less than 2 weeks later, there were 193 total candidates with 42 in some sort of human trial, and there were 10 in phase 3. Now I put an asterisk here. If you answered C, 10, you're correct. If you answered E, none of the above, you're also sort of correct, because 2 of these vaccine candidates that were in phase 3 trials have been put on hold. And I'm going to talk a little bit more about that. Next slide. I'm going to skip through this just for time's sake. Protein subunit vaccines are basically, they take a part of the virus that produces an immune response, like the spike protein in the case of SARS-CoV-2. And these vaccines are usually made by recombinant technology. And the latest phase 3 candidate is the NVX CoV-2373 vaccine that's made by Novavax. It's a recombinant nanoparticle vaccine that uses the spike protein of the SARS-CoV-2 virus. They started phase 3 trials in the UK on September 24th. There should be a US trial starting any day now, if it hasn't already. Phase 1 and 2 trials showed really good safety profile and a good immune response. Surprisingly, In addition to antibody, there was a T cell response, because often protein subunit vaccines don't give the T cell response, they just give an antibody response. But this particular vaccine uses a proprietary adjuvant that they add to the vaccine that causes an influx of those antigen presenting cells. And that's probably what helps it make the T cell response. Next slide, please. Just a couple of things about safety. 2 of the phase 3 trials are on hold in the US. On September, I think it was actually the same day, September 8th, the vaccine that's made by AstraZeneca got put on hold. That hold was released later in the UK, but not in the US. But there's been a lot of concern in the social media, the press. I think just a lot of people are really concerned that this is being rushed and that safety won't be what it should be. But actually on September 8th, the CEOs of 9 major vaccine manufacturers signed a pledge that they would make safety their top priority. Now, this is unprecedented for a bunch of pharmaceutical companies to go together and do this, but I think they felt that it was really necessary due to all the just concern out there, I'll say. Then on October 6th, the FDA stated that there should be at least 2 months of follow-up after completion of full vaccine regimen before submitting an application for approval. Now, I think the good news here is that this really will, I think, make people feel a lot more confident about the safety. The bad news is it's going to probably delay any of the vaccines from coming out before December. Next. Yeah, so as I already said, the AstraZeneca vaccine trial was stopped on September 12th, and then just this past Monday, the Janssen vaccine was also halted due to an unknown illness. I mean, it's known to some people, but it's not known to the general public. At least I haven't seen it, and we don't know how long this pause is going to last. Interestingly, both of these vaccines use the viral vector technology. AstraZeneca's vaccine is a chimpanzee adenovirus. The Janssen vaccine uses adenovirus serotype 26. But it's a little concerning to me that both of these vaccines using the same sort of technology have had some problems, or at least possible problems. Next slide. I want to shift gears quickly and talk just a little bit about vaccine storage requirements. So these are the first vaccines that are likely to come out, I think now, the messenger RNA vaccines. So far, there haven't been any safety concerns. The one produced by Pfizer is called BNT162. The real problem with it is that it has to be kept extremely cold, minus 70 degrees centigrade, which is 94 degrees below 0 Fahrenheit. At first, they were saying it had to be used within a few hours to a day after thawing. Now they're saying that it can be used for up to 5 days after thawing, but you have to keep it in the refrigerator. They have plans to ship it on dry ice, can be stored for 10 days. You have to replenish the dry ice every 2 days and be very careful about exposing the vaccine to higher temperatures. The Moderna vaccine, the mRNA 1273, can be kept at sort of regular freezer temperatures, minus 20 centigrade, which is minus 4 Fahrenheit. And they say at this point that it can be used for about a week after thawing, as long as it's kept in a refrigerator. Next. Excuse me. Next slide, please. Did I cut out again? Thank you. The viral vectored vaccines can really be kept in the refrigerator. They have to be shipped frozen, but you can then store them in the fridge. Next slide, please. But these are both on hold right now. Next. Oh, the note, I'm sorry. Sorry, Taloa, go back one. So the major advantage of this Novavax vaccine is that it can be stored for a long time at refrigerator temperature. It's quite stable at refrigerator temperature, and you can leave it out on the shelf for a while. It's stable at room temperature. It has a long shelf life. So the storage requirements for this are not so concerning. And then I think we're to the last slide, just some resources that you can see. And we're right at the top of the hour. Does anyone have any questions? Comments?
Great. Thank you for a wonderful presentation, 2 wonderful presentations. There is the survey in the link or in the chat box. If you will fill that out, it'll help us improve the sessions. And if there's no questions for Dr. Brown, there's none in the slides or none in the chat. So we can go ahead and end the call if there's no questions. Have a great Friday. Thank you.
Have a good weekend, everybody.